So, good afternoon, everybody. Thank you for joining us for another one of our free MAG educational seminars. Today we have Dr. David Hayes, consultant orthopaedic surgeon, and the session today is about the difference between orthopaedic surgeon and occupational physicians, when and which to engage. Dr. Hayes is a fellow of the Australian Orthopaedic Association with specialisation in knee surgery, sports injury, joint replacement, and arthroscopy. He's been working with MAG for a number of years now and offers regular availability on our booking platform. May I ask that you all remain on mute so noise from the outside world and your workplace doesn't affect the quality of the recording. You'll be able to unmute and ask questions at the end of the presentation, or you can type the questions in the chat box and we'll get to them at the end. The recording will be sent out within a day or so, along with the cover slide. So without further ado, I'll hand over to Dr. Hayes. Thank you so much for giving us your time today and deliver this session for us. That's over to you.
Thank you, Michelle. Hi, everybody. I'm not a slide maker. I have done that in the past, but I think it's probably more engaging to just talk, really, rather than to read slides, because hopefully it hones the message a little bit. Look, regarding this topic, I'm just going to go through my approach to when I see a patient, and then how that interfaces with an occupational physician. So basically, I think orthopaedic surgeons are more front end of a case, and an occupational physician, from my perspective, is more back end in terms of reintegration into workplace. So the way that I normally get to become involved in this side of cases is that there is generally a case which has been prolonged, and it normally should have been assessed by now as being complete. There may be some discrepancy between the opinion of different doctors. There may have been some query about what the mechanism of injury was, whether there's been a past history, and so forth. So when I receive so everybody has a slightly different, they're bringing something slightly different to the table and want something slightly different out of the interaction. So I understand that. What an orthopaedic surgeon is tasked to do is, firstly, to read all of the accompanying literature, but first and foremost, I read everything and then assume nothing, and then temporarily disregard everything, because primarily what I need to do is to take a history about the mechanism of the injury at work, how it happened, and then examine the patient, and then look at the investigations, because that's the basic tenet of what I do in my clinical life. And so I need to make a diagnosis. That's first and foremost the most important thing, because a lot of the time a diagnosis hasn't actually been made. And so there may be a case whereby treatment has commenced, whereby the patient has or worker has had a period of physiotherapy or other modalities of treatment, and this may have been going on for quite some time, but there hasn't been a diagnosis made. And so I'm not specifically interested for that purpose in what the work environment was, but really just listening to what the worker/client has to say, and then determining whether that particular mechanism of injury, together with what's seen on an MRI scan, etc., whether that all matches up and what the diagnosis is. So, for example, if they said they fell down some stairs or they slipped on a wet floor or what have you, then does that, if their knee twisted, does that line up with a meniscal tear, as opposed to, oh look, I was just walking along and I fell on I fell on the front of my knee, and now there's a big meniscus tear. So for me, I'd say, well, you don't get a meniscus tear by falling on your kneecap. So that's the first red flag for me, is that the mechanism of the injury doesn't line up with what the MRI is showing. So it either does or it doesn't. If it doesn't, then that then leads me down a pathway of going, okay, well, what else, or what else could have caused this? What else is going on? So that's the most important thing that I bring, that an orthopaedic surgeon will bring to the table. And once that's occurred, it's interesting in the history taking, the worker will often say, they'll give you quite a vivid description of the work conditions, and that, well, if it hadn't have been for the conveyor belt, not having been cleaned and so forth and so forth. And whilst so that's all very important to put into a report and to document, it's a little bit extraneous to what my primary purpose is, which is to get the diagnosis. Now, after that, the circumstances around the workplace which are claimed to have happened can then be documented as well. And it's really interesting how I can sense when there's the more descriptive and of the workplace, and how they never want this to happen to anybody else, and how it was that they'd previously reported that this was a problem and it wasn't right and so forth. All of these things are starting to stack up. I'm thinking, okay, this is starting to get a little bit away from the medical diagnosis, and this is starting to get more into other non-medical factors, if you follow my drift. So it's important to, once you get to then causation outside of once you've made I've made the diagnosis, it will then become often the case that we'll get drawn into that relay of what the patient has stated and or what they've omitted to say. And then that then will set up, again at the front end, often the supplementary reports once you get my report, and then say, well, hang on, I've got an employer here whose version of events is actually completely different to this. Or in fact, we've got video which says, it shows, can you have a look at this, which shows that none of this happened at all. And so quite often I'll say, I'll look at that and do I say, well, now that I know that, that's really interesting, because that's just a totally different description of what happened to what I was told. And so from your end, it will say, well, which one is it? Could it be this? And I said, yes, it could be. It could be that it didn't happen at work. And if there's no, sometimes it's very clear that there was no injury. Sometimes it's not clear that there was no injury. And so it can become frustrating, because I suspect, I get that, from your end, it can become quite frustrating, because you kind of have a lot of red flags where you think, this just doesn't ring true. But all I can do is go on hard evidence and the mechanism of injury, sometimes you get to a stalemate where, and so anything beyond the medical becomes, a civil or workplace situation rather than an orthopaedic situation. So I think that's the first thing. And being drawn into that, all I can really say is, look, there's a possibility or a probability if it's not really clear. And then I guess, in my own personal opinion, sometimes if you get to an end point whereby there's a stalemate, sometimes it may be better to just go, all right, whatever the treatment is, let's just get it done and get this person treated, because ultimately it's going to be a shorter, less costly claim if we just get it done, because it's going to drag out and it's going to drag on, et cetera, et cetera. So they're just some of my personal feelings on that. But I think by and large, the more descriptive a person and acrimonious a client is, the more likely that it is that there wasn't a particular work injury. The other important thing that ties in, as you guys know, is past history, and it's very important, very much something that's an orthopaedic specialty where we provide a knowledge of what the natural progression of an underlying condition is, and the chronicity of what you might see. So, for example, somebody who, say, falls on their kneecap and has kneecap pain, and so, well, I never had any pain. This is, as you know, this is a common one. I never had any pain before I fell on my kneecap at work. And the MRI scan will show widespread damage to the back of the kneecap. And part of my job is to say, well, look, this is clearly, all of this did not happen at the time of that fall. And this is an exacerbation. It's not a specific injury that happened. It doesn't need specific surgical intervention. And then it becomes a little bit of there are some general guidelines, but it's up to me and orthopaedic surgeons to provide you with prognostic guidelines. So firstly, not an acute injury, an aggravation. And then prognostic guidelines is to say, okay, how long, how much time is enough? What's reasonable for this aggravation to be over? And look, for most, I mean, this is a big generalisation, but for most things, 3 months, 4 at the outside would be the absolute most. And so if it's somebody who has no accompanying pain syndrome or psychological adjustment to injury, which we all know is going to prolong things, and we all can have our own opinion on how valid that is or isn't. If someone's a straight shooter and straight up and down the line, it's about an aggravation is about 6 weeks. If there's other factors, it's just realistic that I said, look, I'm not going to be doing you guys any favors by saying this is going to take 6 weeks, it's going to take 3 months. But at the end of that, that's it. Cut it out, stop it. Now, at that point, is where what you guys want to know is, all right, well, we're moving through the case and getting towards the back end. And, well, how do we get this guy back into work, and at what rate, and so forth? So an occupational physician, so I can give you, and do give you, advice regarding that. But my advice about returning to work and timeframes roles, etc., is based on a couple of things. Firstly, it's based on, number one, not putting you guys in a situation where you're going to be liable for any worsening of the natural course of their condition. So it's protective of the patient, and it's protective of you as well. Because if I say, look, he can go back or she can go back to work straight away, you know, in 6 weeks and be absolutely fine. And if that's not the case, then it sets the employer and yourselves up for being liable. So that's first and foremost. Secondly, if surgery has been done, I certainly don't want that to be messed up by having an increased risk of further injury by going back to work too soon. So that's how an orthopaedic surgeon will come at return to work plans, is by thinking of worst case scenario first and then going backwards from there. So then it becomes, well, can we institute this, and this at work? And so then it becomes, from my perspective, really more of an estimate of, like, well, how much pain and immobility should there be at this particular time? So there's, you know, that's based on general parameters. Bit of guesswork too, I must admit. An occupational physician, on the other hand, specialises in the prevention, diagnosis and treatment of work-related illnesses and injuries, not all of them orthopaedic, and aims to ensure the health and safety of workers across various industries. So the part of, and that's both individual and on a company policy level. So, for example, they'll engage in workplace hazard assessment and risk assessment on a more general level. They will be a collaborator more between someone like an orthopaedic surgeon and a workplace health and safety officer or occupational therapist in designing and approving the specifics of return to work programs in a number of different industries. So they have a deeper understanding of the physical environments and ergonomics of specific occupations, and so the tin tacks and the nuts and bolts of you know, the specific tasks, the number of days and weeks, number of hours, etc., is I think more in the domain of an occupational physician. So, as I said, quite often they're across a specific industry and might specialise in a specific industry, but across industries and larger companies in general, and then they're very skilled at then being able to adapt that to the needs of a particular individual. But once they have, but that needs to be once they have had the front end teased out and have a very good working knowledge from the front end about, you know, an orthopaedic surgeon saying, well, this bit's true, this bit isn't true, and this is what it is, and this is how long it will take, and this is what the treatment will be, and then it kind of merges back into the return to work where the occupational physician will do their thing. I think that's really in a nutshell, to be honest. Is there anything in that I haven't answered for you, or that you have any questions about?
I'll just roach the group. Is there anyone in the seminar that would like to ask Dr. Hayes some questions? You're welcome to pop it in the chat or unmute yourself. I do have a question that I did get from someone who wasn't able to attend. So it was from a lawyer, Kathleen Goff. She said, are there any red flags or indicators in a referral brief that help you determine when an occupational physician might have been more appropriate?
Yeah, for sure. I think that multiple attempts to return to work, which have failed, and multiple different people involved, and for whatever reason, there's always a sticking point. So I know that the diagnosis and the treatment has been completed and has been appropriate, but there may be someone who really needs more understanding of where there might be some wool being pulled over the eyes, and there's just too many people and too many attempts to go back to work. Someone who's got a thorough understanding of that industry and can liaise on a more of a ground level with the the health and safety specialists of that particular organisation would be more valuable in that scenario.
No problem. Did anyone have any more questions? No? Okay. Well, thank you so much, Dr. Hayes. That was very interesting and I'm sure helpful to our referring clients to help them identify when to engage either an orthopaedic surgeon or an occupational physician. With that, I think we can probably wrap up if no one... Oh, wait, we've got one question in the chat. Are occupational physicians okay with assessing psych injuries, or is it just more physical injuries?
Yeah, they're more. They would definitely be able to do that. So if you were to draw a diagram of it, then out on the perimeter you have orthopedic surgeon, psychiatrist, other specific specialists who have a specific entity that they're addressing. And then once it would be the same for a psychiatrist. Once a diagnosis and a prognosis and a time frame has been identified, that then can be used by an occupational therapist by an occupational physician to then assist them with reintegrating back into the workplace. There are some specifics that, for example, so the answer is yes. And infectious diseases, or really any specialty outside that's one step removed from the workplace, then an occupational physician is then able to reintegrate it at the back end pretty well.
Beautiful, thank you. So, and Helen in chat said thank you. I do have another question from Morgan. A bit off topic, but as an orthopedic surgeon, when referring someone to you for an IME, would you prefer to have an MRI done prior, or would you refer the claimant if needed?
Well, it does help very much for me to have the MRI to be very succinct and clear in the diagnosis on the first on the initial report. A couple of things there. One of them is that the workflow from your end, from the insurer, is time sensitive and critical, and so I accept that. And sometimes that means that an MRI can't be done before they're referred. So I understand that aspect of it. Sometimes it doesn't need to be done. So you may be, if it's there, I love it. If it's relevant to the case. If it isn't, it ends up in a supplementary report, and we all, accept that. I don't know how to get around that all the time, because I think it's more of a time. My understanding is it's more of a time-sensitive thing in having a report of some significance in some nature in a certain time frame. And so I'm happy to work within those parameters on a logistical scale. But yeah, medically speaking, it would be superior if we could,
Yeah, perfect. Well, Morgan, I hope that does help with your question. Thank you again, Dr. Hayes. We will wrap up there. So thank you so much for sharing your expertise with us today and your time. Thank you everyone who attended today. The recording will be sent out to you within a day or so. Have a great rest of the day, and we look forward to seeing everyone at the next seminar.
Okay, thanks everyone. Thank you very much, Michelle. Take care.